Well, this masterclass, Next Gen Surgical Robotics Training, explores how India can scale robotic surgery safely, affordably, and efficiently. This discussion will examine national readiness, infrastructure requirements, credential standards, and the shift towards competency based robotic training. This session will also explore indigenous robotic systems, make in India innovations, and the emergence of AI enabled operations that are redefining surgical practice. Now, ladies and gentlemen, to lead this masterclass, please welcome with a huge round of applause Dr. Ashwin Tamhankar, consultant urological oncology and robotic surgery, Dinanath Mangeshkar Hospital, Pune. A very warm welcome, sir.
Good afternoon, everyone. Without further ado, I think we have only 1 hour to go for, and this is the whole discussion which a lot of youngsters I can see here who have been probably enthusiastic in robotic training and robotic systems. We thought that this discussion will be pertinent for two reasons. One is initially how the robotic systems work, what robotic surgery actually means, and then later half we will have a discussion around public-private partnership and how to strengthen the programs. So I'm humbled to announce my panel here. Dr. Sajal Sen, he is Officer of Special Duty of Assam government and MERD, has profound experience in a lot of research work, especially with the robotics. So please, Dr. Avinash Supe, sir is ex-Dean KM Hospital and Director of PD Hinduja Hospital. He's a gastroenterological surgeon himself. Dr. Chinnababu Sunkavalli. He's a surgical oncologist with vast experience of robotic surgeries in Yashoda Cancer Institute, Hyderabad. Dr. Rooma Sinha, she's a surgical gynecologist at Apollo Hospitals and has done maximum number of robotic procedures in gynecological surgeries in India. And very own professor and head Tata Memorial Hospital, Dr. Gagan Prakash. He heads the Department of Uro-Oncology at Tata Memorial Hospital, Parel. So we just thought that when we have this particular session for an hour, we will try and have a moderation rather than having separate talks or separate versions. And this particular thing is going to be restricted to non-orthopedic robots. Sadly, I can see some orthopedic colleagues, of course, but this is more into coelomic robots where we have utility in different types of surgeries, and we'll dwell into the details of it. So let's start off with the presentation. Can I have the video started in the background? So for some inquisitive minds here, this is how actually the robot looks inside. Dr. Gagan, do you want to elaborate on what all are the advantages? There are two screens. Dr. Gagan, you want to see at this particular screen? Whichever is convenient. Sorry, there are two
this
screens.
is fine. Thanks, Ashwin. So essentially, we are talking about advantages of lap over open and then robotic over lap. But what you can see over here is that the instruments have a greater degree of movement, which is thanks to something called as the endorist, a concept which tries to replicate what the human hand is doing with a much miniaturized form. And of course, we are talking about a three-dimensional image and much magnified. So it is something like operating while watching on an IMAX 3D wearing those goggles. And
Perfect.
whether these perceived advantages are actually translating into better outcomes is what we'll be taking you through during this panel.
Wonderful. So this is a procedure of a partial nephrectomy which has been demonstrated. We are working on the kidney tumor. We have resected the tumor off, and now we are creating or reconstructing the trench in the kidney by maneuvering the sutures across the kidney tissue. So that's what the finish means. And this surgery is done for cancers in the kidneys. So typically, Dr. Rooma Sinha, laparoscopic surgery generally makes surgeons' life in long-term difficult because of difficulties in ergonomics. Do you agree on that? And what is the differentiation with the robot because of that?
Thank you, Ashwin, and I would really like to put this address that for Pulse and the organizers for having this wonderful session and having the hall so full. Thank you for being here. I've been a laparoscopic surgeon for many years before I took up doing robotics 15 years back. There are definitely some disadvantages in doing laparoscopic surgery like a through-dimensional vision, a straight stick laparoscopy, and things like that. But do you know, Ashwin, working over years of 15, almost 15 years with robot, I realized there are two things other than the vision that we are talking about that makes me a better surgeon. One is the tremor filtration. Now, if you look at the human hand, we work with human hand. The tremor filtration at the end of a stick is always going to be there, irrespective of your age. It happens more when your arm is more tired at the end of a 3-hour surgery. So this filtration, if the machine filters out, I'm more confident in doing my precise surgery exactly at the place I want to do. The second, human hand always has macro movements, doesn't have micro movements, and the movement that you saw. How does that happen? And that's the concept called motion scaling, which means if I move my hand or my fingers 1 centimeter, I can set the machine to move 1 millimeter inside the patient. And that's how I achieve my precision. So these are two very big advantages to me as a surgeon when I use this
So it's
platform.
basically advantage gained rather than the advantage lost, because in laparoscopy sometimes because of the fulcrum effect you have more movement happening inside the tummy than outside.
Yeah, so there are
It's exactly
many
opposite.
nuances just for the public.
Absolutely.
I wanted to mention two.
Absolutely, yes.
I want others to
So
speak
you
to.
agree that it is a boon for a surgeon?
Come again?
You agree that it is a boon for a surgeon?
Yes, because
Absolutely.
everybody, when they talk about that this is beneficial to patient and small incisions. But we have all that in laparoscopy.
Yeah.
I want to speak from my point of
So
view.
probably you will go on till age of 80 as well performing the surgeries?
I hope to die in a robotic theater.
All right. Okay, all right.
If that could be true.
So
Maybe
that,
am I just cutting out of a surgery and go?
all right.
Would be the ideal way.
The next thing which comes to Dr. Chinnababu is, so it's boon for surgeon, definitely yes. Is it a boon for patient as well? Because that is the most ultimate outcome which we are looking at. We should be safe for the patients. Outcome should be better. So what edge a robotic surgery gives compared to a conventional surgery?
Thank you, Dr. Ashwin, for this opportunity. Yeah, I think at the end of the day, whether you do open surgery, laparoscopy, or robotic, I think the center of the whole care is the patient. What is the advantage for the patient? I think, one thing that I want to mention here is there is something called the patient value for everything that you do, whichever type of surgery that you may choose. So the patient value, if you see, it is directly proportional to the efficiency. So whichever method you choose, lab, open or robotic, it should be, efficiency should not be compromised.
Absolutely.
But what is the most important point is the patient value is inversely proportional to invasiveness square.
Right.
That means to say less the invasiveness, more the patient value.
Absolutely.
So you might say laparoscopy is also minimally invasive, right? But what is the advantage of robotic system? I think the biggest advantage what I find for my patients is in terms of the trauma to the patient is much less because, as you rightly mentioned, fulcrum movement.
Yeah.
So even with laparoscopy, there is more pain at the port side, whereas in robotic, that pain is not there.
Absolutely.
And because of your better vision that you have,
Yeah.
3D vision, 10 times magnified vision, your trauma to the tissue is much less, blood loss is much less, the infection rates, the recovery is much faster, even compared to laparoscopy.
So you can basically give good justice to cancer when it comes to cancer treatment in terms of good outcomes, and non-cancerous treatments also, generally the outcomes are better. So which was the first, Dr. Gagan, which was the first surgery it's a debatable question, but which was the first surgery which was done for robotic procedure in globe?
Yeah, so I'm
Can
not
we
sure
have the
if,
volume on that particular side little less? Opposite. It's creating some hindrance.
Yeah. So I'm not sure. I'm not having the details of this story, but I believe the whole idea that a surgical robot should be developed actually came from NASA. So that's when NASA was developing the space station, and amongst all the needs of the space station, one of the things was that if a surgery is needed, how would that happen? And probably they asked Stanford to develop a system. The space station never happened, but I think the robot was developed, and then Intuitive took the lead. I believe initially thinking that it would be an instrument to be used by cardiac surgeons because you're requiring precision in a depth actually, but later on I think the urologists kind of
That's good.
took over, and prostatectomy
Actually,
became
Ashwin,
the
I'd like to mention a name here.
Yeah.
I'm sure you know Dr. Mani Menon.
Yeah.
He's an Indian origin surgeon in Detroit, and he was the one who took lead because he realized by doing
Absolutely.
radical prostatectomy was very difficult doing
Yeah.
laparoscopy, and he turned the whole story around.
And that changed the path completely.
That
in last.
changed
So
the
this
path.
was year 2000.
So it's an Indian mind again working there.
Yes,
So that's
absolutely.
something to be
And
proud of.
you know, this was also thanks to the fact that PSA screening was rising at that point of time. The number
Correct.
of prostatectomies were increasing.
Correct.
And
So Dr. Puntambekar is not here. Maybe I'll ask it to Dr. Gagan or Dr. Chinnababu. You have seen various versions of robotics, especially the intuitive surgicals or Da Vinci. Currently, there are about 213 or more installations of intuitive surgicals here. What advantage does the robot gives us or what advantages you have seen in terms of serial versions? So compared to Da Vinci Xi, which is the 4th generation, what advantages you have gathered in terms of giving safe outcomes to the patients?
I think, in terms of the generation wise, if you see, the size of the machine has come down.
Yeah.
So the initial versions, we used to have much bulkier
Bulky
machines.
camera, bulky
Yeah.
machines.
So
Yeah.
now that, you have a 8 port for camera and all the instruments
Yeah.
instead of the 12 port for the
Absolutely.
camera. And other than that, I think the multi-quadrant surgery, what we can do with the, boom that we have, I think this is the more advantage that we have in XI system compared to the
Previous
older
versions, absolutely.
versions.
Plus the advantages like Firefly, table
Firefly
motion
tech,
sync.
yeah.
So you can see the table actually moving. Sorry, let's go back. And yeah, is the video playing? That's okay. So Supe sir, that's the pictorial representation of surgeries
Hello.
being performed
Hello.
with respect to
Sure.
specialities. So
Okay.
just to give a disclaimer, there are multiple specialities which have maximal advantage of these kind of robots.
Fine.
So can you elaborate on that, sir?
Sure. I think over years, what you realize that though urology and pelvic surgeries were the leaders, oncology were the leaders actually, they are still leaders because they have a proved kind of an advantage in literature. But many other surgeries like general surgery now is taking over now, and it is coming up. Another very fast growing surgery is TORS, according to me. Transoral resectional surgeries. All those morbidities of commando, instead of that, if there are smaller lesions, we can really do transoral surgeries with minimal morbidity with equal outcomes. Though there is a little outcome advantages there, but TOS is picking up very big. Even thoracoscopic esophagectomies and all are picking up very well. So I think, though today still, according to me, urology, gynecology and oncology are the three main kind of forerunners. Over a period of time, we will see the other specialities are coming
Absolutely.
up slowly over a
So
period of time.
this is 23 data wherein you have maximum numbers coming from general surgery now, which wasn't the case in 2018. If you see the crossing of the graph, 2018 still the urology was the front runner. Now the general surgery is the front runner across the globe. Now let's see what's the situation in India. India still urology leads the overall gamut of treatment, and there is a significant upslope. And general surgery, gynecology, other branches have significantly grown. The numbers in last 3 years have dramatized in India. General surgery wise, we are again reaching the first peak. So 16,000 procedures being performed in 2025 for general surgery, because you have a lot of indications there and it's a more common procedure. Then comes the urology and then comes the gynecology, because in urology and gynecology, the predominant section is cancer oriented or some disease oriented. That's something which we need to agree. So yeah,
Ashwin, do you want to at this point have a raise of hands of how many surgeons are there in the audience?
how
and
many surgeons
many
in the audience?
medicals,
Fantastic.
and how
Alright.
many doctors,
many-
non-surgeon doctors?
How many students? That's good. That is more encouraging to us. That's brilliant. Yeah, medical students, right? Whichever, someone who is interested in robotics. That's good.
All students are good.
All students are good.
All students
yeah,
are
yeah,
good.
absolutely.
And
yes.
we are anyway. We are all students.
Yes.
Yes.
So, so this is a nice representation called "Crossing the Chasm" by Geoffrey Moore. Basically, for a robotic procedure, it takes about 16% utilization by a particular technique to call that procedure as a reasonably mainstream market procedure, which gynecology and general surgery, so gynecology and urology is already there. They are about 80-85%. So basically what this graph means is urological cancer procedures, if being done, out of 100, nearly 85-90 will be robotic across the globe. Likewise, gynecological minimal invasive procedures, if being done, roughly nearly 80% will be preferably robotic, and thoracic and general surgery are slowly creeping up, but all have already crossed the crossing of the chasm path at 16% mark. Now coming to the day case procedure, Dr. Rooma, that's the most deserving field. I think hysterectomy is where you're not dealing with any other organ, just removal of the uterus for some disease, and we are not anticipating a lot of complications potentially, of course. So how does that change in your regular practice? Do you do day case surgeries in India with robot?
Thank you, Ashwin, because I think for the audience here and the students, if you understand, women undergoing surgery, hysterectomy is one of the commonest surgeries. Right?
Absolutely.
It's a midline pelvic organ. Using the robot with two hands from two sides is an ideal situation.
Yeah.
Although, let me make it clear to the audience, all hysterectomies are not the same.
Yeah.
You may have stage 4 endometriosis, which can be much more
Terrible,
difficult than an oncology.
Than a cancer as
Or
well.
you could have a large fibroid where handling a large specimen intraoperatively may be a challenging situation.
Absolutely.
So the robot does help us in these challenging situations to do hysterectomy safely and with minimal access. I'm a benign gynecological surgeon. I don't do oncology, but I firmly believe that any woman requiring a gynecological surgery does not deserve an open surgery today.
Absolutely.
Whether I use laparoscopy or I use my robotic instruments to do it, I should do it. And I think this should be the aim of all gynecologists, to train themselves in minimal access surgery and do not wait for, say, endometrial cancer to develop to offer them robotic surgery. We should offer them when they have fibroids as well.
Absolutely.
So, that's the story here.
Correct. So basically, this representation means that probably we are slowly heading towards day case procedures. So these procedures being major surgeries, which needed about 4-5 days of hospitalization in an open era, now patient can be literally sent home next day, or maybe a little adventurous step on the same day if all goes well.
All patients go the next day in our practice now.
That's good.
Just 24 hours stay, that's all.
So something similar has come up in urology for Dr. Gagan. You want to add on prostatectomies a bit quickly?
Yes, so I mean, prostatectomy, even though it's a little more complex surgery because you're talking about an anastomosis joining the bladder to the urethra, there's a lot of suturing involved, but still, because of the less invasive nature of the surgery, there are reports of it being done as a daycare procedure. Now, in terms of what is relevant for India, whether it can be done as a daycare, yes. Whether it should be done as a daycare, probably I wouldn't agree for that.
Absolutely.
I think the whole cost of stay is probably not so much of a problem for our country.
Sure.
And maybe a surgery which entails lymph node dissection, sometimes the chances of urine leak,
Absolutely.
even though it's much lesser.
But we are definitely discharging patients probably within 48 to 72 hours. That's what a standard of care is, which never used to be in the previous past. Now coming to so this was until the intuitive era was happening for last year 2000 till 2022 or 2023. And then came some revolution in different types of robots because there were a lot of patents of intuitive which slowly started weaning off and new robotic systems came into picture. This diagram I have represented here just for some engineers around or some engineering students around, that for establishing a robotic methodology or a technique for actual patient use takes good amount of years of investment in the background. So see the graph, this is a graph for Cambridge Medical Robot, CMR. They started in 2014 and their actual trials happened in India itself in Pune in 2019. So 5 years was the investment phase in the preclinical setting and pre-cadaveric settings before they actually had actual robotic surgeries. So open console versus closed console. So I have predominantly all three surgeons who are working on closed console. Sadly, I was expecting someone who would be there for open console as well. Sir, sir has done it. So what's the situation? As in, do you like open console more? So basically what it means is Intuitive, or the original company of the robot which already had, was an immersive console wherein you will peep into the machine, see the three-dimensional picture and operate. Open console is something which you will see as a monitor, wear a 3D goggle and sort of operate with that. So
see, we have a CMR. We have been trained in CMR.
Yeah.
So we use open only.
Yes.
Actually, CMR has little limitations compared to Da Vinci, but now they have also got ICG and it is.
Yes.
The advantage of CMR is that there is an individual thing, so you can do all important
sir.
surgeries, you can move them.
About the
I
console,
think it's more comfortable for a
Absolutely.
surgeon than the immersive, but I'm sure the other technical advantages of Da Vinci make it different.
Okay. So basically, it means you have to keep doing what you're doing regularly, and then you will succeed and you will have good outcomes eventually. So that's something which is important. These are some new robots which came into picture in last 2-3 years. Senhance, Revoi from South Korea, Avatara from German robot. Then we have Hinotori from Japanese, and now 3 last figures are the ones which are now also installed in India. Is Yugo Robot, which is Medtronic. SS Innovations, Dr. Srivastava. He was supposed to be on the panel. Some last minute cancellations happened, but he's a cardiac surgeon himself, and he had a lot of efforts getting into the SS Mantra Innovations, which they tried indigenizing. They have about 180 installations across the country, out of which about 15 are in the government institutions, and they have serial versions of Mantra 1, 2, and 3.0. And recently we have Merrill Robot. So my orthopedic colleagues will be quite happy because they have robust robots in orthopedic joint replacements also. So likewise, what we have for Coelomic is Meso robot. So these are the new robots which we have so far. Supe sir, if you want to talk about single port. So until now, basically a robotic system will have 3 or 4 arms, essentially majoritarily 4 arms, where you will use all 4 arms simultaneously or one after the other and perform the surgery. Then came an era few years back, about 5 years back, of single port surgery.
See, actually, if you see, single port surgery came about 20 years ago,
Agree.
but it did not pick up very much.
Yes.
But now with Da Vinci SP coming up, I
Yes.
think there have been now trying to bring one tube you put in. I'm sure you can do things like appendicectomy and other small operations can be easily done with a single robot.
Absolutely.
Easy to set up
Yes.
with only one port, and probably it is more convenient for surgeon if you really train yourself according to that.
Yes.
Maybe you'll be able to give less morbidity to the patient,
Yes.
and maybe you'll be able to do better.
Would you be happy using it for benign
Ashwin,
hysterectomies?
I have seen this
Yeah.
robot being used, and
Yeah.
especially with my travels in Southeast Asia.
Yes.
It's very good for midline, single, quadrant surgery.
Yeah.
And so gynecology actually fits the bill. So doing myomectomy or hysterectomy with single port would be quite ideal.
Yeah.
And it has become very popular in Southeast Asia, especially in Korea, because of the cosmetic value.
Yeah.
Because many times you have to understand, as surgeons and students here, that we may do a surgery, but extracting that specimen is also one job. And we need to make some incision somewhere to take that out safely.
Yeah.
Often we go with a umbilical incision, which is our primary port to do the surgery. What better than using that same port,
for
to do
camera
everything, get the specimen extracted safely
Absolutely.
out, and give the woman a very, very simple scar, and she is happy.
Yes.
So I think it will take off
Absolutely.
gynecology. We still don't have it in India.
Correct. So we have some utilizations in urology for single port as well. Let's skip this for the want of time. There are certain robots, Dr. Chinnababu. Intuitive had a lung biopsy version of robot called Eon. Of course, we haven't used it. All of us haven't seen it in India. But supposedly it gives a phenomenal navigation to target a small biopsy to diagnose early lung cancer, which is the very common cancer in West. So do you believe in that strategy coming? Suppose if it is available in India, would you be happy using it?
Yeah, I think definitely it helps in diagnosis in a single day.
Absolutely.
I think the daycare procedure where the patient walks in with a small nodule,
Correct.
you do the navigation biopsy, center
Correct.
frozen, and do a segmentectomy or wide excision then and there itself.
Correct.
This is actually typically a daycare surgery even for a lung lesions.
Absolutely.
But I think in our setting, it's still far away. Is my practical way of looking at it.
Yes.
Sure. It is still far fetched. Yeah, it has to evolve.
It would take some time. But this is what happens. Probably 20 years back, we were saying robotic surgery will be very far-fetched in India. Today, we stand at 20, 30 surgeries every month, individually, all the surgeons here. So that's something which is important. Coming to Dr. Sajal Sen. Dr. Sajal, yeah. So do you want to talk about nanorobotics a bit? Can you mute the audio of this? Yeah. Nanorobotics and nanosurgery. Some pointers towards the trainees here.
Yeah, actually, this is an emerging science. And it has been emerging. Richard Feynman, who was the father of nanotechnology, way back in 1950, he made a statement that given the time, we will swallow a surgeon who will perform the procedure and come out of it. So this was the statement he made so many years back, that the surgeon should be so small that you can swallow it, it goes into your system and comes back. This is the fundamentals of nanotechnology in nanomedicine.
Absolutely. So,
So as of now, I think India or I think Chinese have got some idea, some breakthrough in the nanorobotics, but mostly they are being utilized for drug delivery, and quantum dots are being used for a specific imaging purpose. So at present, nanorobots are restricted to these two areas only.
absolutely.
Specific precision surgeries is not happening.
Appendectomies. That's nice. That's nice. So the next leap. So basically, we are going through the journey of robotic surgery start way back in 2000, and now we are at 26 years ahead. And last couple of years, there is a lot of boom about telesurgery. Essentially, for students, it means you are performing a surgery in a remote center where the OR is not existing for the same patient. The patient is anesthetized somewhere else, quite a bit of distance apart, and that distance can be 10 miles to 6,000 kilometers as well. It just needs good amount of 5G connection these days with a minimal lag, and then the surgery has been performed. So Dr. Gagan, do you want to address about current equations of telesurgery and the picture? This picture got quite famous at this point of time around a couple of weeks back, where Dr. Prakash Dasgupta performed UK's first telesurgery, but in India we had done it earlier as well. Yeah.
Yeah. So I think the technological feasibility of it happened with our understanding that if one can fly a drone, many light years away on another planet, sitting in the Earth on this planet, why not the same bandwidth can be used to kind of transfer the movements from the console to the robot. And essentially, what was required was that whatever the surgeon is doing, that should immediately be transmitted to the system. And once that became possible, it was just a matter of trying how the surgery could be done remotely. And right from a few miles to few thousands of miles, those things have been done and seen that it is feasible. However, there are concerns, particularly related to certain regulations, certain safety concerns, because just in case there happens to be a problem intraoperatively, the main surgeon is not there. There could be there could be other bedside surgeons. So it's an evolving field, but I think in terms of taking complex surgery or skilled surgeries to areas or parts of the world where surgeons may not be there, this can be probably explored.
Absolutely. So
Sure.
basically, the key motto is the surgery should be
Ashwin.
a safe surgery, and it probably would translate into utilization for
Ashwin,
masses.
can I say something?
Yes.
The Hinduja hospital has a tie-up with Kings.
Yeah.
So we work with Prakash Dasgupta, who
Absolutely.
has retired now.
Yes.
Now see, he was the one who did it, but when these tele-remote surgeries were done, there was initially a lag of few seconds.
Yeah.
And that was a common problem of really doing it. But now with the newer thing, they
Absolutely.
have been able to reduce that time.
Yes.
So now they are able to do this
Absolutely.
very well. So now I think is a era will come
Yes.
with definitely people will do it with more precision.
Absolutely. Only concerns are sometimes if you have a complication, it's going to be difficult to handle that situation. So it's not something which is a routine situation for everyday affair. It's something which is selectively for two centers, and both centers should be well equipped to salvage any problems associated with it.
Can I-
Dr. Rooma.
I think
So a lot of surgeons will have hesitation for this.
No,
I
not-
can see that.
okay.
I can sense that.
we all have our takes and
Yes,
thoughts on it.
absolutely.
Number one, it's fantastic the way technology is developing.
Yes.
I think our generation has seen leaps and bounds, and this is the ability to do sitting here and do a surgery in the next city or a next continent is mind-boggling.
Absolutely.
However, as of now, what clinical application I see is a collaboration.
Yes.
Supposing you are sitting in Pune and I'm operating in Hyderabad,
Yeah.
and I need your expert help on 2 or 3 steps on the surgery that I'm performing.
Yes.
I could hand over my console to you,
Yes.
sitting at Pune, you connect, you do that 3 steps for me, and I come back and do it as if I had called you in my theater if I
Absolutely.
needed
It's,
you.
it's more of a
I think
teleproctoring
that
and
is what
telementoring.
we
Rooma-
need to actually do it right now.
Rooma,
Yes.
exactly yesterday night, we had a King's College surgical grand round where there was a presentation on tele-remote proctoring.
Yes.
Absolutely.
And this is
Yes.
exactly what they presented. that
So-
whether for
it
some
is-
steps
it is not-
somebody can help
Yeah,
you
so
in
it's
that.
not putting any patient in any danger. The surgeon is capable of doing the surgery.
Yeah.
But yes, many times during surgery, we find a step which is difficult. And
Abs-
I've worked with Dr. Chinna quite a lot.
Yes.
Many times we would collaborate, call him in our theater. Okay, you know, have a look. Do you want to help in this day? And he walks away after that.
Absolutely.
That can happen with 5G remotely and it's fantastic.
Absolutely.
So a
Dr.
remote
Ashwin.
surgeon can take help of me,
Yes.
of my skill, to do a 5 steps in endometriosis and continue.
That's right.
Right.
Dr.
I
Chinnababu.
think I just wanted to add, telesurgery is not a new concept.
Yeah.
Because the first telesurgery was done way back in 2001, Operation Lindbergh.
I just
The
mentioned that.
Transatlantic, you
correct.
mentioned that, right? So
Yeah.
Given that, I think maybe in the future you would have an option of working from home for surgeons.
I hope so. Especially with the COVID.
I wish.
Especially with the COVID. Especially with the
We'll all
COVID.
move to
I-
Goa, sit near the beach.
Yeah. So this is the
I
first. Yes, sir.
No,
Good.
no. I thought
So this is the first phase which we covered about how the robotic journey has been through in last 2 decades, more than 2.5 decades, not just in India but beyond. Now we'll come to the next half of this session where we'll have focus on how to take it to the masses, how to have more public PPP agreements and stuff. So 2 words which I'm going to be using, Dr. Sajal, what do you think and think about our decentralization for a robotic training?
You see, already a lot of tier 2 and tier 3 cities have adopted robotic surgery.
Yes.
I know very smaller towns, Bhubaneswar, Raipur, Jabalpur, so many places.
Yes.
Some of the surgeons have adopted. That's my first
Yes.
statement. The second part is that, you need a complete team to be trained and proctored. You are just not the surgeon.
Yeah.
So once you get the surgeon, you need to have a complete team. This is what I faced in Guwahati. When we in medical college, 2 colleges, we got robotic surgery and we got the surgeons trained. But then we found that they were not proceeding more than 1 surgery a month because they were always skeptical about the capabilities of the team.
Correct.
So to democratize, you have to develop a cadre of people who would stick to the robot and be with the surgeon for the entire duration. Number 1. Now, last point I'll make is that the cost is one of the inhibitive factors.
We'll come
as
to
of
that, sir.
now.
We'll come to
Yeah.
that in the subsequent
Yeah.
slides. Yeah.
Okay.
So democratization. So Supe sir, one word has been explained. Decentralization, meaning you have it more installed in not just central cities but peripheries, tier 2, tier 3 cities. What is the democratization of robotic system?
See, there are 3 things in this kind of thing.
Yeah.
One is cost, second is infrastructure, third is training of people.
Yes.
Now, in training of people, I'm sure we can do. That's not a big problem in India. We can train
Correct.
more people. The problem is of infrastructure
Correct.
and the cost of
Just.
the whole recurrent cost. Now, when you are saying I want to democratize, we have to, I think all these mantra and all are bringing down the recurrent cost of this.
Yes.
So that one will probably help us to grow into it. See, same thing happened with the CT scans and MRI.
Yes.
MRI and CT scans were initially in 88 and 90 were
Jewel.
limited to only 1.
Yeah.
Now you find every taluka level has 2-3 MRIs and 2-3
Agreed.
CTs.
Absolutely.
The same thing is going to happen with robotics.
Yes.
So when you are democrating, what we need to do is we need to bring down the cost of recurrent costs.
Absolutely.
We need to start building infrastructure,
Yes.
have a large scale training program in medical colleges and around.
Correct.
And then what we need to do is we need to have a proctoring for some period of time
Absolutely. Correct.
because we do not want complications. So
Yes.
the higher centers should really proctor, watch it carefully, and then I'm sure this will spread.
Absolutely.
And I think, as Chinnababu rightly said, there are definitely few advantages of some robotic surgeries.
Yeah.
Less pain, better better kind of a rotation, even AWR above, reverse suturing,
Yes.
and then pelvic and all. These are all have to be given to the common man.
Absolutely.
This is where you go and democratization will occur.
So, of course, when we talk about these 2 terminologies, the barriers which come into mind, they have already elaborated that cost should be brought down. It should be well utilized, viable, survivable machine at a tier 2 or a tier 3 city because the cost per procedure is quite significant. And most importantly, we should not be compromising on the quality and the safety outcomes of the patient. Just for the heck of having it done at peripheries, you can't propose a machine there. The whole infrastructure and a environment has to be created for better outcomes. So, Dr. Sajal, you had put a lot of efforts. I was amazed to read through that article. It's called Atharva. Do you want to elaborate on that?
Yeah, this is basically, finally, the democratization will also happen if we start developing the product in India.
Indigenously.
So
yes.
it has to be a Viksit Bharat dream. It has to be a Viksit Bharat dream. And with that, our government of Assam gave me a lot of grants to develop two products. One was a low field millitesla MRIs with permanent magnet which can be moved. And the second project was related to Atharva, related to robots. So this one we have been able to crack it, and the software is open source. And therefore, again, the monopoly in the software is not, it's like Android. You can buy a phone and the software will be there. And it is working, the arm is working. Now, this year we are planning to take it to animal model where we will have the multi-arm. But of course, we are not looking at a single port solution as of now. It would be a
Correct.
multi-port. But at least we have made a beginning, and it's
That's nice.
It's a
That's
wonderful
quite encouraging, and it probably needs
that's
a
the
round
picture
of
of
applause
that,
quickly because it's something which is
product.
indigenized. First version, of course, it's a prototype. It will have another multiple miles of journey to come for a clinical utility, but that's the first step. Well begun. The next part is quality control. Dr. Chinnababu, if we are talking about tier 2, tier 3 cities. We are not in Hyderabad, not in Mumbai, not in Pune. Probably Pune can be tier 2 for you, but I'll just
Tier
for
one.
sake of so
Ashwin there, Pune is tier 1.
correct. So we are talking about something in periphery in Vijayawada, somewhere Satara. So how do you want to ensure quality control there for robotic training
I
as in
think-
robotic surgeries?
No, I think we need to move away from the vendor-driven certification to some kind of a credential system should be put in place. Right now, we don't have.
Correct.
Whichever is the company that is manufacturing, they are coming and training. So I
Correct.
think there should be a unified credentialing system,
Correct.
which can really help us to, kind of give some kind of a objective performance indices.
Correct.
That OPIs are the new word actually, which actually, because today I can come out of the theater and say the surgery was very difficult
Right.
for the patient attendants, but how do they believe? What is the way of really measuring it?
See,
Yeah.
the classic way, if you look at Singapore or other countries, they have gone into the tired level of credentialing.
Yeah.
That means there is something called as a robo start.
Yeah.
Now, once he completes a robo start, and these are not done by the vendor,
Yeah.
these are done by the institutions or
Correct.
associations,
Right.
and they do at a particular level.
Yeah.
And then he's supposed to do this simple surgery,
Yes.
Yeah.
and then they go on to the complexities of those
So-
surgeries. So, tired kind of a robotic
Yes.
training program
Yeah.
is something the need of the hour.
I would
So
actually like to put a point here that what Chinna said, training is important.
Yeah. So
I think
just exactly
we
the same.
We can have safety by training the surgeons and the team properly,
Yeah.
not just the
So
surgeon.
for training a new novice surgeon in a
So-
tier 2 city,
So just to give you
Yeah.
a background, we have an association of gynae robotic surgeons in India,
Yeah.
which I founded 3 years back,
yes,
has a 3 level of training.
yes,
And this is in collaboration with the same curriculum which is being used in Europe.
absolutely.
So any gynecologist who wants to learn robotics today can go through with this step 1,
Yeah.
which is just on simulation, learn the console.
Yeah.
Level 2, learn the surgeries, and then level 3, get credentialed.
Yeah.
So these are 3 levels, very
But
standardized
Correct.
method of training, and that's how we can assure
But a counter
safety.
question here is a novice surgeon who has not gone through this formal training wants to perform a procedure. Does the governance say no to him?
No,
That's
No.
a sad part of it.
I would say no.
That's a sad. So that's
Yes.
what the sentence which I
See,
just mentioned.
You won't fly a aircraft without training, right?
Yeah, yeah.
Why do you want to do robotic
So that's
surgery without
something
training?
which is an
Question.
important message that everyone is a robotic surgeon, so-called robotic surgeon in 2026 now when we talk about decentralization and democratization. But we need to be very cautious about safe outcomes. Just for the heck of doing it or being present, it should not be done. That's something which is important. Dr. Sajal, can governance put some efforts in this direction? That's what I wanted to bring forward.
Yes, exactly. Like the government, see, the entire medical world is about, it is self-credentialing and self-controlling.
Correct.
Our medical council and all is basically meant that the doctors themselves decide the rule and then they follow. That is the model India follows.
Absolutely.
Similarly, in the robotic surgery part also, I think the association should come forward and develop credentialing programs, and they should use the statutory bodies to get the certification done. If you have done so many hours and if the Gyne Robotic Surgery Society has credentialed you, then the NMC has to give a certification that so many hours
That's
they
the
have
need
done.
of the
just
hour right
giving
now.
an
That's the
example.
need.
Absolutely.
Like
Without
TAVI does
credentialing,
it.
they can't
Yes,
do.
When
absolutely.
people started doing TAVI,
So there has to be some dry lab
then 5 procedures
simulation.
you have
So
to
many.
done with Proctor.
Yes.
I think robotic companies have to make it sure that.
No, and you
I
all
don't think it is robotic companies.
They are vendors,
They are
essentially,
companies.
yeah.
They are vendors. They want
No,
to sell
no.
their machine and make
It
profit.
should be governance.
Yes, it
No,
should be
no.
governance.
I'll add here.
Probably
I'll add here.
DMER.
See, there are certain places where the procedure number is also given. Take kidney transplant.
Yeah.
They have given that a general surgeon can do kidney transplant under the Act, provided he has done
Training.
25 surgeries with the surgeon and 5 independent
Yes.
under observation.
Fair enough.
So
Fair
similar
enough.
kind of guidelines the surgeons community
Correct.
has to
So imagine
develop.
this-
And to be followed strictly.
And
Correct.
should be followed.
Ah,
That can be
absolutely.
done.
Not
Yeah.
just a paper.
That's an important message.
Yeah.
Just giving an example, if NDTV World can put this article across, when actually I went into details of it, it wasn't actually a big fault as a part of procedure, but it was quite highlighted in a bizarre manner. You can imagine what Indian media will do if such circumstance happen in the periphery when we are talking about decentralization. So that's something which worries my mind. And as I said, with great power comes responsibility, which we need to follow through. Now the learning curve. Every procedure, it's not that I got some dry lab curriculum covered, I got certified maybe through some stepwise progression in gynecology or whatever, but still every procedure will have learning curve. Dr. Gagan, especially we are talking about urological cancers where we focus on both cancer outcomes and functional recovery outcomes. So
Yeah, so essentially this whole conceptual learning curve is established, and it has been defined for different surgery that these are the number of surgeries you need to, these are the numbers. Only if you cross these numbers, you're likely to go past that learning curve. And these learning curves have also been further divided into from an oncological point of view and also from a functional point of view. For example, in a case of prostatectomy, one might be able to complete a prostatectomy as a surgery, but may not be able to give the best functional outcome in terms of continence or in terms of nerve sparing and things like that. So these numbers have been defined across various surgeries.
So
and one
for
has
example,
to
this
follow those.
prostatectomy, it takes about odd 300 cases to actually become proficient, which probably a urologist who is doing predominantly urology work will never complete in years, in the entire lifetime probably. That's a sad truth of it. So that's something which is important, and that brings me to the discussion about subspecialized practitioner fellowship training. So Intuitive, currently in India, we have about 41 fellowships which are sponsored by Intuitive through US for training new novice surgeons in various specialties: urology, general surgery, gynecology, and surgical oncology. That's something which is important, that we need to establish similar kind of fellowship trainings through the governance, through the local authorities for taking it forward for a structured formulated programs. And that's how the certification means. So every certification of Intuitive would have mentioned how many console hours a person has worked for, how many procedures he has done independently, etc., etc. That's one of my credentials from UK. I just put this picture for the sake of doing it. Reason being that these were my bosses in UK. The entire gamut of treatment in UK is not even subject specific, it is organ specific, meaning one surgeon performs only prostate surgeries, another surgeon will perform only bladder cancer surgeries, third person will perform only kidney cancer surgeries. So that's something which we are trying to imagine for better outcomes of the patient here, and we are quite a bit of years in ahead of it, unfortunately, sorry, lacking in it. Now the practice before surgery. So we are talking about safe outcomes for decentralized and democratized robotic systems in periphery, where we need to have some simulations. A surgeon should be exercising the procedure before he actually performs the procedure through some virtual reality, and that's called as Manning hypothesis. You practice before you play. That's something which is important. So does that have a role, Supe sir?
I think what today people are doing is, especially the urological institutions, I saw one nice, they do patient-specific simulation kind of thing. For example, you're operating on a tumor,
Yes.
renal tumor, then they would create a model with gel
Yes.
and they inject it and create a model.
Yes.
And it's a real model.
Absolutely. Yes.
Actually, and then he has to perform it with safely up to particular level.
Correct.
And then only he is allowed to operate.
Yes.
This is what they are being doing in many countries, especially for difficult kind of thing.
Yes.
They make 3D, digital twins, all that thing. But I think for a routine surgeon, he should be able to achieve up to particular percentage before he is allowed to go
Absolutely.
in a further complex surgery.
Absolutely. So this is something which is a virtual 3D printing, virtual model which looks like a difficult kidney tumor for a complex anatomy of kidneys which are joined to each other. We call it horseshoe kidney, wherein we have that green thing is a tumor. We actually are virtually removing it, not intraoperatively. We are doing it prior to the surgery as an exercise to understand what all anticipated difficulties we will have when we actually perform the procedure. That's something which is important. That's called as 3D printing. I'll ask this question to Dr. Sajal Sen. Sir, any efforts on, because you have a lot of research facilities and this would need ground reality work. Do you think this would be a very routine affair for us in another 5 years?
Oh, yes, yes. This is basically the thing which we are looking at, to
Yes.
create a robotic surgery trainer, even by using electronic cadavers and digital cadavers, and also using the models.
Correct.
Because finally, even the flights are, the pilots are also trained on simulators. And robotic surgery is also, you have to have certain number of hours on simulation before you touch a patient. And good quality simulators will bring in very good outcomes.
Ashwin, it will
Yeah.
give an information. The same digital twin we are using very routinely for our myomectomies,
Yes.
especially when we have multiple myomas.
Correct.
We have good experience of cases
Correct.
in which we have created this digital twin.
Yeah.
Do a kind of subtraction surgery
Yeah.
and see how to locate the myomas
Correct.
intraoperatively and go ahead and do that.
Yeah.
And also collaborated with some institute in Canada, and
Yeah.
maybe Dr. Sajal might be interested, and we can collaborate of using the MRI DICOM images to
Yeah.
create, say, endometriosis, 3D model, and do a virtual reality surgery using the meta headsets before we get into the theater. So maybe we could collaborate and work on that more.
Absolutely. So we are slowly evolving towards it. Dr. Gagan, so we basically, this is pre-surgery. We are trying to work before we actually perform a surgery, maybe one day prior. But if that assistance can be provided during the surgery, especially for a kidney tumor, which is a complex tumor associated closely to the vessels, what would be your thought process?
Yeah, so essentially about navigation, so whereas preparedness before the surgery with all kinds of digital technology now, and then with that preparedness, if that can be incorporated during the surgery, that helps you navigate during the surgery is what is happening. And I think this is also the zone where the whole AI thing is, also playing a lot of role. I mean, in the future, we are going to, as we would operate, the AI models would tell us that you are approaching a vessel. It might even tell us that,
Stop.
few months back you had a problem in this area, please be careful.
Correct.
And things like that. Yeah.
I wish that day comes at some point of time. So the second part is, now the last couple of slides, we are going to be investing on utility of robotic systems and whether the health insurance companies actually put a lot of efforts in covering that. There is a lot of challenge in that. And luckily I have a variegated panel who represent different spectrum of hospitals. So I'll start with this. Gagan sir, at Tata Memorial Hospital, are you, how many percentage times are you bothered by the patients about health insurance not covering the robot? What is your challenge at Tata Memorial?
Yeah, so see, Tata Memorial Hospital is a central government organization, which means that a lot of central government employees and those retired from the central government would be coming to us. Now, typically what happens is that any organization would say that these surgeries could be done robotically, or they're allowing those surgeries to be done robotically. For example, in urology, prostatectomy and partial nephrectomy is something which, if I give to a CGHS employee, they say, okay, you can go ahead with this surgery. But the day I bring out a new surgery, I say cystectomy also I want to do robotically, then I need to justify why for this particular patient this has to be done. And these things are, there would be a parallel story for private insurances also.
Correct.
Now, these things are going to get a little complex with newer robots coming in, where the cost of doing the surgery in some of the newer robots has actually come down. In a good way, it has come down. but which means that the same robotic surgery may have different costing on different platforms, and that may
That's going to be a
complicate
challenge.
things, yeah.
Dr. Rooma Sinha at Apollo Hospitals, how many percentage you will have challenge in getting the robotic system, robotic surgery pre-sanctioned?
No, I wouldn't say 100%, 80-20.
But 80% you will have a challenge, right?
I will have a challenge. I will have to
Same
justify
stands
with
with me in my
each
practice.
case
Yeah,
to say why I want to do it robotically.
correct.
More so because I do benign surgeries.
Yeah,
If
correct.
it was oncology, they would have said yes.
No, it's the same. It's the same path. I
Sir?
have the
Okay.
80-20%.
Okay, then I'm
as
not
well.
bad. Right.
Yeah.
But for every patient, I have to give an explanation
Correct.
of why I do. And so that is the reason why we are not able to offer it to all patients.
Yes. So something which I wanted to give as a message to the governance, it's more of a government of Maharashtra's directed activity. Something needs to be done for these kind of efforts. When we are talking about decentralization, democratization, the first step is to let people avail this procedure under insurance because people would demand that. That's something which is important. Sir wanted to say something? Yeah.
I think some of these surgeries
Yeah.
where the robotic definitely has advantage or others,
Yes.
they should be really considered for health insurance, even if it's a MPJY. You know, we may really, some hospitals will definitely take it.
Absolutely.
In a private hospital, I'm sure, as Madam rightly said, 80% of times you have a challenge of getting that robotic surgery
Correct.
passed.
Right.
But I think some patients, even in a public sector,
Correct.
or those who are wearing MPJY and
Correct.
there's a robot available, I think they should be given this chance. I think
Absolutely.
there's a need to go one step ahead
Yeah.
now.
So we are going to the last phase of it, that we are trying to have capacity building to have India as one of the lead position holders in robotic surgery markets across the globe. And important pillar of that is medical tourism. Dr. Rooma, approximately how many patients, international patients, do you operate for gynecological robotic surgeries in a year or on a monthly basis?
Okay, I'll ask you to define the international patients because the international patients
So
in my practice
anyone
are,
who is beyond India.
are two types.
Correct.
One is the real international patients who come to India for treatment and they are international passport
Not the
holders.
NRIs one, not the NRIs.
But the
one
NRI
who are actually
ones are the big chunk.
Yeah.
Believe me.
Yeah.
And especially patients coming from Canada, USA,
Correct.
and UK.
Correct.
Because they come and beg me, ma'am, do it in 2 weeks
Correct.
because I'm getting appointment for 2 years
6
later
months.
for a fibroid I'm bleeding on.
Yeah.
And I'm overstressed to accommodate them
Agreed.
in my schedule. But that's this medical tourism I think India should target,
Correct.
not the other tourism. And that's going to be a big chunk because of the lack of availability of infrastructure.
And more of ease of treatment in India.
And they feel comfortable coming back home. Many of
Yeah.
them have family. Great.
So very, very true statement here. People will have 6 months of waiting time even for an MRI scan outside, which we have it overnight here in case we need it. That's something we are blessed for in India. Believe me in what I'm saying. And all of us have seen this across years and decades. So the cost of any procedure, compare any procedure, we are nearly 1/4 lesser than US, 1/3 lesser than or 1/3 to UK standards, and half the Thailand and Singapore standards for the comparative cost. So we can have this utility better, and that's what we strive for. Now coming to the last bit of it, that we spoke about surgeon training, surgeon oriented discussions. But to actually run the robotic show, which sir was mentioning earlier, you actually need a comprehensive efforts for the entire team to push forward, which not just includes surgeons, but a hell lot of people along with that, as the along with the team, which includes some OT technicians, nurses, bedside assistants, anesthetists, pathologists, everyone. Sir wanted to say.
See, I think when we had started CMR 3 years ago,
Yes.
we trained OT technicians,
Absolutely.
even our ward boys,
Yeah.
even our nurses, and they all went and they got trained.
Absolutely.
And everybody had 3 days common session, and one was specific to their task.
Correct.
I think these kind of a multidisciplinary team training for
Correct.
a center to start
Absolutely.
is absolutely essential.
Yes.
And these need to be started now if you want to take it to the second and third tiers.
Absolutely. So it's not just the training of surgeon, but a comprehensive team, and that team has to be doing consistent efforts to make surgeries safer and better in terms of outcomes for the patients. One of my articles in cystectomy, we call it Pandavas. So you need a comprehensive team of console surgeon, a good fellow, expert bedside assistant, a good anesthetist, of course, who is friendly, and nurse practitioner for stoma care. All those things are needed for giving a good outcome for patients of cystectomy, which are morbid surgeries in general. Now, the last bit about publish or perish. So when we talk about a lot of decentralization, democratization, a lot of volumes growing, we also need to talk about publishing those, showcasing those to the global positioning. And that's something which is important, because when we were trainees, we never had good data to refer to from Indian cohort of patients. Today, that slowly the leap of movement has started, and we have enough data now on various spectrums, on various locations. That's more to encourage people here. But point which I wanted to bring forth is, it's very easy for people in the West to publish easily, because I can give you 2 papers of mine where I had analyzed the data of almost 500,000 prostate biopsies over 1 decade in UK NHS. And I didn't have to sit down to jot down that data for donkey's years. I just had 2 days to get that data retrieved for me. I just had to assimilate that data and put some productive efforts out of it. So that's something which we are lacking in India today. Something similar, a data of 12,000 cystectomies, which we can't, UK being such a small place, probably India must be doing 10 times more numbers of than this for cystectomies, but sadly we don't have good collaborative efforts and data. So something anyone can pitch in. Gagan sir, Rooma madam, yeah.
I think with EHR coming up, and we are now, see, the biggest problem of our place is we don't have an searchable EHRs.
Yes.
So I think unless now many private hospitals have a good kind of a data, but unless now when we want numbers, like say KEM now has started HMIs, and I think over a period of time, when we will start developing that data, then searching that data, putting into all this will come. Now ABHA is also coming.
Correct.
So I think in the next 10 years, I feel we will have lot of pool data. Now, what is important is not only searchable data, but pool data for this thing. Look at NHS, look at the Netherlands. They pool all centers and then bring out such wonderful papers. We are still about 10 years behind this. But it will happen.
So our association that we have started, Gynae Robotic Surgeons of India, we have started a registry. So we have at the moment roped in 5 centers where we are doing without intervention of any robotic company. It's just sponsored by the association. We are starting a registry for a 5-year duration of following these patients up for something. And that will be such a robust data here, which will actually not. Individual level, we are all trying to publish. As he said, publish or perish. And publication remains your legacy. You have to make a lot of effort in the private sector to do that. Believe me. The time is at the essence. There is no support. Nobody pays you to do that. But I think some of us do. So I personally have more than 70 publications now. So that's great.
So,
Ashwin, just wanted to say that I feel that probably this is the strongest message from this conversation.
Talk today,
We are not lacking in skills. We are not lacking in technology. We are not lacking in expertise. What we are lacking is to pulling up all the good work that we are doing and showcase it to the world. And I think prioritizing that on individual bodies, I mean, every society, whether it's a urology or GI or Gynec society, should be prioritizing this over maybe the very conferences and other things that we're doing.
Absolutely. That's my last slide, which I would want to probably summarize. So when we talk about positioning India as the leader in the robotic surgery market and talking about Vikasit Bharat and Vikasit Maharashtra year 2047. So of course, I'm pertinent for robotic training and robotic system. So patients, surgeons and hospitals will be the central pillar of it. So we have to give good amount of exposure, good amount of enable them for good amount of infrastructure, allow them to have facilities, good training. Then comes the second rim around it, which is innovation and integration, where we'll have new procedures invented, new directions, new surgical insights. Then comes the training and education part, and this alludes to training of the allied staff as well, not just surgeon training, the whole OR staff and everyone. And we have support and analytics, which essentially means data registry, publishing. So basically, this is what probably I would say we have to discriminate between what we need to do for masses and what we need to do for classes. So probably I would say for the masses, the entire discussion which we did on decentralization and democratization stands true. And for the classes, probably we should be positioning ourselves into some better neurosurgeries, high-end surgeries where we'll have better outcomes and monitoring, auditing the outcomes as well. So probably I will sum up by saying this. We had few pointers which we tried incorporating in this. Is new installations are welcome, but they would come with some responsibility. That's something which is important. Capacity building is more important for fellowship train and more importantly for You need to have fellowship trained surgeons. You need to have handholding of these new surgeons who have not been trained formally, but for telementoring, teleproctoring. A good for an oncological training, a subspecialty path is very important for giving good outcomes on both cancer and function. Decentralization for surgeries which are little low demanding surgery. No surgery is an inferior surgery compared to other surgery. I'm not here to say that, but a little low demanding surgeries where you have possible less complications can be thought of decentralized in a decentralized manner in an easy way. You need to have data registry and repository for research, and the cost metrics will come down with some indigenous models, innovations, and collaborative efforts with IITs and other spectrums. So thank you so much. Probably we are exactly at 3 o'clock. By the time we have 4 minutes left, any questions pertinent can we take for a minute or couple of minutes?
Absolutely.
The
If you have
whole
any
panel is here.
questions, if you could raise your hand and we'll get the mic right to you.
How do you perceive or would like to address the threat of viruses and hacking of the robotic software?
That's a brilliant question. So again, Intuitive had, at least I can talk to you about Intuitive per se, because that's something which is established in year 2000. It's a 26 years of journey for them. The newer systems are still in the phase of infancy, being very honest with you, for their development. They will have another versions. For them to match up to the skills of the existing players, it will take good amount of years. Hacking is not a major issue because they have some foolproof systems, but software malformations sometimes do happen, but they are probably 1 in 1 million, and they are majority never intraoperatively. So probably we have never faced an intraoperative challenge. Occasionally a robot may have shown an error even before starting the procedure, and we may have stopped the procedure even before starting it or even before commencing it. But that's a theoretical risk which always exists, which probably sometimes we document when we counsel the patients, but that's very rare in situation, at least with the existing teams.
Many of our conferences have
Yeah.
sessions where we say horrors or what has happened to me. 1 or 2 people have said that how they were stuck into robots. But mainly these are technical. Nobody has really talked about hacking or software.
Yeah. You never know. That can happen really.
But in telesurgery, patient confidentiality is again some area we must
Yes.
take care of.
So it can
It's
be one of the types of wars. You never know.
Unless we've given the idea for the next Robin Cook novel,
Yes, that's correct.
Well, thank you. Do we have another question? We do have time for one question.
One question. Any trainees? We would like to have a question from a trainee.
Well, no negative points for any wrong questions. So please take this opportunity. Very rarely we have such wonderful leaders on stage.
Let's ask how many of you would want to become a robotic surgeon now?
Wow.
Okay, some good.
How many of would like to work to innovate newer robotic platforms?
So we have more engineers
Work with
than
surgeons
medical
and
people
make
here.
new platforms.
Welcome, ma'am. Well, that was absolutely insightful and a forward-looking masterclass.